You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael. Dr. Mikhael is a professor in the Clinical Genomics and Therapeutics Division at the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center. He is also the Chief Medical Officer of the International Myeloma Foundation. Dr. Mikhael is a consultant hematologist and Director of Myeloma Research at the Honor Health Research Institute, where he conducts Phase 1 clinical trials. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, this is Dr. Joseph Mikhael, and welcome to Season 2 of the Medscape In Discussion Multiple Myeloma podcast series. Today, we have the exciting opportunity to take out a crystal ball and to look into the future, as our title today is, What is the Future of Multiple Myeloma? And I honestly cannot think of anyone more qualified to be prophet-like looking into the future than my dear friend and former colleague at Mayo Clinic and still lifelong colleague, Dr. Shaji Kumar. Dr. Shaji Kumar is a consultant and professor and researcher in the field of multiple myeloma at Mayo Clinic in Rochester, Minnesota. He, in fact, leads the whole myeloma program across all of the Mayo Clinic enterprise. I could spend hours talking about all that Shaji has accomplished, but one key thing I would say about Shaji is that he really has brought the whole spectrum of myeloma in his career. He's worked from bench to bedside. He's worked in frontline therapy and relapse therapy. He's really worked across the whole spectrum. And that's why I think he's particularly qualified today to have this conversation as we think about the future of myeloma. So, Dr. Kumar, welcome to Medscape In Discussion Multiple Myeloma podcast.
Thank you, Dr. Mikhael. Thank you for having me on this podcast. Look forward to our discussion.
Well, that's it. You can't call me Dr. Mikhael anymore. It's just Joe and Shaji from now on. So, obviously I put you in a bit of a tough situation because it's one thing to talk about a trial that's already been conducted and how you apply it in the clinic and so on. But I do think that it's worth looking into the future. And you and I, when we started in myeloma 20 years ago, sadly, most of our patients didn't live much more than a year. We had very few diagnostic and therapeutic options for our patients, and it really was a dismal disease. I can even say I know one of the reasons why I went into myeloma. One of my high school classmates developed myeloma in his 20s, and I wanted to take care of the patients that were the sickest of the sick, as it were. But now, wow, what has happened over the last 25 years? Now expected survival is well over a decade. We have over 20 drugs approved. We have radically improved, I would suggest, both the quality and the quantity of life of our patients with myeloma. But it ain't over yet. We have a lot more to do. And so what I was hoping to do with you today, Shaji, was to sort of think about a few different areas and what the future may look like in those areas. And you have done a lot of work in the lab. You've been very much involved in our diagnostic criteria for the IMWG. Mayo Clinic more recently has moved to a new modality of testing for myeloma compared to the historical serum protein electrophoresis and serum free light chain assay that we use. So let me ask you about diagnostic tools in myeloma, Shaji. What do you see the future? Are we all going to go to mass spec like myeloma, or is the skeletal survey truly dead now and we really should only be using PETs or MRIs, or is it going to be PET MRI? I mean, I could not put words in your mouth. You tell me. What do you see the future of diagnostics in myeloma?
So you're so right. I mean, it's amazing the progress that has been made in the past 2 decades in every aspect of myeloma therapy, diagnostics, and as you said, taking care of the patient as a whole. The whole concept, I can't think of it better represented in any cancer than it has been in myeloma. And the technology is often ahead of sometimes therapy, but myeloma may be one place where therapy might be a little bit ahead of diagnostic, but that's not to say that diagnosis hasn't changed. One of the advantages we have for myeloma is that the cancer cells secrete a protein that we can measure in the blood, which many cancers don't have, where we have to rely entirely on imaging. So we have an inbuilt biomarker that has been the cornerstone of myeloma diagnosis for almost 6 decades since Dr. Kyle described many of these conditions. And when you look at the myeloma, more from the diagnosis standpoint and also for monitoring the response to therapy, there are certain things we look for. We can look at this protein that is secreted by the myeloma cell in the blood or in the urine. We can look for the cells themselves in the bone marrow or in the bloodstream or in soft tissue in the form of plasmacytomas by using imaging. And increasingly, what we are seeing is that we cannot really look for the disease in just one aspect. We have to look at it, every one of these three sites that we talked about, in order to get a comprehensive understanding. And this is important not only for diagnosis and classifying the patient in terms of where in the spectrum from monoclonal gammopathy of undetermined significance to active myeloma to plasma leukemia they are, but also in terms of prognostication. So clearly in the blood and the urine, looking for the protein, we did the protein electrophoresis for the longest time. We did the immunofixation electrophoresis for the longest time in order to quantitative and qualitative assessment of the monoclonal protein. And as you mentioned, we have now switched to the mass spectrometry based assessment, which is not only more sensitive, at least a log more sensitive, it is also more specific or accurate. You can clearly know what you are looking at very small amounts. And importantly, it is much more easy to do. For example, as you said, the Mayo switched the methodology. We went from a huge lab to basically 10 tabletop machines with a 4 or 5 people who run the lab now. The footprint has gotten to be substantially smaller. The number of people needed to do the test are much less, and the turnaround time is quite fast.
So let me ask about that for a moment. So you've gone to mass spec now, so you're not doing the old school serum protein electrophoresis. And I'm sure we both have a little PTSD of doing that as fellows in the lab. But how quick is that turnaround time now with the mass spec? I mean, we've sometimes structured our whole clinics around having a patient come in a week before they see us so that we can get those blood tests done and have the results back. I mean, when I think about the future of myeloma, could it be that someone comes into the clinic and half an hour later you have the result of the mass spec? I mean, how quick is your turnaround?
Well, half an hour, maybe not yet there, but within 24 hours, we have it. If they get their blood drawn before 10 a.m., we can have it before 5 p.m.
Wow. Okay. So because I do think logistically that would really speed things up. I mean, I know, of course, when I worked at Mayo here in Arizona and for you in Rochester, sometimes you have people traveling from quite a distance. And so they would end up having to have an extra 3 days at the hotel right there in beautiful downtown Rochester, so that they could get the testing done. So I think it has a pragmatic point of timing. The other point that I thought was very good that you made was it's more accurate, not only in quantifying, but differentiating different kinds of proteins. Like right now, a lot of our labs don't discriminate the IgG kappa if it's coming from a drug like daratumumab or isatuximab. And so we have a lot of patients saying, oh no, I still have this M spike of 0.2, when in fact we can say, no, actually that's the DARA, that's the ISA when it's done by mass spec.
Exactly. And that is, I think, quite timely when we're thinking about the monoclonal antibodies becoming mainstream. I think it's quite timely that we went to mass
Absolutely.
spec.
Well, before we leave the diagnostics, let me ask you two quick questions actually about diagnostics. One, do you think that we can do less bone marrows in the future? Are we going to have the technologies you said, whether we look for the protein or the cells in the blood? And then the second question will be, what do you see about the future of imaging? I would love to do fewer bone marrows on our patients. Do you think that's going to happen?
Absolutely. I think it's only a matter of time. So the first step I think is going to happen is we are going to do less bone marrows because we will know what is the right time to do a bone marrow based on the mass spectrometry testing. So if you were to wait until the mass spec becomes negative to do the bone marrow, you can be assured that they at least have less than 5% plasma cells and obviously more likely to be MRD negative if you are trying to use that for your response assessment and MRD testing. So, but at the baseline, I think everybody will need a bone marrow, but the subsequent bone marrows during the disease therapy is going to be less often. Going fast forward a little bit more, I think it's only a matter of time before we can get the blood assay sensitive enough that it actually picks up everything that's in the bone marrow. Right now, all the testing that we have in the peripheral blood, whether we are looking for intact cells or looking for the DNA from the tumor cells, it seems to be at least a log less sensitive than what it
Mm.
has been in the bone marrow itself. But I think that's going to change for two different reasons. One, I think as the patients are living longer, many of these patients tend to have disease outside the bone marrow, and that may not be picked up by a bone marrow biopsy. And two, I think the sensitivity of those peripheral blood tests are going to increase, and we can actually sequence extremely small amount of DNA out of the blood in the future, which will be, I think, a much more globally representative of the tumor everywhere in the body.
Yeah, that's fascinating. I'm also fascinated by the fact that the technology now is, I mean, we can, I mean, I work at a translational genomics research institute where, we're developed a test now with just on the peripheral blood, we can literally fully sequence someone's myeloma. It's remarkable.
It's remarkable what we can do. I mean, certainly there's a lot more we need to understand because then, it may not show all the abnormalities that may be present in the bone marrow. So we need to get to a point where the sensitivity is good enough that it captures everything.
Absolutely. And then my last question on diagnosis, because I know we got to talk about therapy. It's amazing. There's so much to talk about in myeloma, but do you think we're going to have much of a change in imaging, or do you think now it'll just PET and whole body low dose CT or will rule the day?
I think we are moving to a place where this cultural survey should no longer be considered standard of care. Certainly, in resource restrained environments, I think it's reasonable to at least do that. But I think the basic minimum should be a whole body low dose cultural survey. Ideally, every patient with myeloma should have either a PET CT at baseline or a functional whole body MRI at baseline. Because what we are seeing is one, if you have extramedullary disease and a diagnosis or a relapse, it's a poor prognostic indicator. But we can also follow that lesion using a functional imaging study. But on top of the soft tissue disease, what we are seeing is the changes in the bone marrow itself in terms of the activity. It has an additional value in terms of predicting the depth of response. So I think in future we're going to have ideally everybody get a baseline MRI or a PET CT, which then will be followed up once they get to be MRD negative, mass spec negative, is the imaging also become negative.
Perfect. Well, you heard it first here at the Medscape in Discussion Multiple Myeloma podcast from the world famous Shaji Kumar. That's how we're going to be diagnostically looking at patients in the future. Well, let's shift our focus for a minute, Shaji, and talk about therapy. And we often get so excited about relapse therapies, and we always have new, exciting modalities, which we'll come to in a moment. So let's talk a little bit about sort of frontline therapy and maintenance, and then we can talk later about relapse. But there really has been a lot of change in frontline therapy. We had a great discussion with Saad Usmani about quadruplets and how they've really, for the vast majority of patients, now have become the standard of care. But if you look into, again, your crystal ball into 5 and 10 years from now, what do you see as major themes for frontline therapy? Are we going to still be doing quads? Are we going to be transplanting patients? Are we going to CAR T cell therapy? Are we going to be doing bispecifics up front? All of the above. What do you think?
Yeah, it's really amazing how much it has changed, especially the past 5 years in terms of frontline therapy. It took forever to go from just dexamethasone to a doublet. Then it took a long time to go to a triplet. It really took not a long time from a triplet to go to a quadruplet because of the efficacy of the new therapies. And I think, the data from the Perseus trial, I mean, that is amazing when you're talking about a dexamethasone injection and a single transplant and no maintenance with 3-year PFS. And now we are talking about a quadruplet induction therapy, single transplant, 2 drug maintenance, giving you maybe a 15-year progression-free survival.
Amazing.
That is
Amazing.
just a 5-fold
5
improvement
times
in
as long. It's incredible.
just the first line therapy. And if you're talking about somebody who is 65, that person is 80 already. And if you can get them one more therapy that will give them 15 more years, they're not going to be talking about myeloma
Yeah.
for that particular person. So if you're really looking at a paradigm where the average patient with myeloma might need no more than 3 lines of therapy to get them through their entire
Wow.
lifespan. So where can we go from here, right? I think that's going to be the interesting thing. The first question that comes up always is transplant going to be there? If I were to predict, I would say the transplant's going to go away. The question is what is going to replace the transplant? I think the quadruplet regimen with a doublet maintenance without transplant might still give us a long enough PFS that we could think about transplant in a more selective manner. People who don't get the long PFS then might be getting a transplant, or maybe may be getting a CAR T. That clinical trials will tell us. But the people who do very well with the quadruplet and not transplant might go 15 years and they might get immunotherapy at that point in time. Now, this is assuming that the quadruplet remains a standard. We're already starting to see the immunotherapy agents, the bispecific antibodies, combine that with daratumumab and lenalidomide. We are seeing very, very deep responses. So if they truly tend to become an improvement over quadruplets, we could be talking about a bispecific antibody, an IMiD, and an anti-CD38 monoclonal antibody used together for a limited period of time which then gives people 10 to 15 years of treatment-free interval. I think that's the key next improvement.
I think you've hit the nail on the head. I mean, not that we can definitely know what's coming in the future, but what I really liked about what you said was it's not just more is better, right? Because I think we're hitting the edge of that by we going from singlets to doublets to triplets to quadruplets. I love the fact that you didn't say, "Oh yeah, next thing we're do is have 5 drugs," right? Like it's and then six. Do I hear 7? I mean, at some point it's a bit ridiculous. But not only so, you've commented that paradoxically, it might actually mean a shorter time on therapy. What I've learned even through the quadruplets is this concept that if we can combine these multimodalities with very effective therapies that can be overlapping because the toxicity is not overlapping, we have that possibility to actually get people into that deep, durable remission and then take them off therapy so that they can get onto my favorite drug, as I say all the time, nada, nothing, right? Everybody loves to be on nothing. Do you think MRD is going to be a part of that and risk status? Is that going to help us determine, as you sort of noted, that some people may not ever need a transplant, others might, but some people can stop therapy earlier on?
Absolutely. And I think the two tools we have, one is obviously the risk status, and I think that is going to be a key element. And the second is the depth of response. To me, the treatment of myeloma is going to get individualized primarily based on three factors. One is the frailty at baseline, which will tell you how much of treatment you can give, the risk status, which tells you how much of treatment you need to give, and the third thing being the depth of response, which tells you how long you need to give the treatment. And the depth of response, again, the patients who are MRD negative, at some point we should be able to discontinue their therapy. And I think we're already starting to see some of it. Right? We saw the Midas trial where obviously the transplant was dependent on the MRD status. We have the data from the Perseus trial showing that lenalidomide could be discontinued in people who are MRD negative after 2 years of dual drug maintenance. And we hopefully will see similar data from the SWAG trial that is looking at daratumumab lenalidomide maintenance. So increasingly, the trials are going to look at the sum total of the risk and the depth of response to determine how long and how much therapy we need to give to an individual patient.
I think that's a fantastic prediction. And I think that reflects the biology of the disease, right? We have some patients that need treatment for longer. But I think overall, if I think of all the patients I've just treated, let's say for the last year, there's no doubt that I've had people on maintenance therapy who probably could be off of it if I could just better predict what would happen with them. And I think what I'm hearing from you as we look to the future of multiple myeloma on this podcast, that we are going to be able, with those three factors that you noted, baseline frailty, risk status, and depth of response, we'll be able to have a more individualized pattern of determining what do you need, how long do you need it, always with the goal of getting people off therapy. I mean, that might be one of the greatest benefits of CAR T cell therapy, is that on the whole, we've been able to stop therapy in patients. I know it's tough to make you answer this, but do you think we'll be doing a lot of CAR T up front?
I think we will be doing a fair amount of CAR-T, even maybe not right away today, but I think in the next 5 years, as the CAR-Ts are becoming more safer, we're already seeing the signs of that. That we can develop CAR-Ts without the lentiviral vector. We can actually give CAR-Ts without the high rate of CRS and neurological toxicity. So I think the next generation, or maybe the generation after that, of CAR-T is going to be a lot safer than what it is today. And that is what's going to take the CAR-T to become part of the frontline therapy.
Well, that's a perfect segue into our final chapter, which is to think about really what excites Shaji Kumar about the future of myeloma in relapse multiple myeloma. I mean, when you think of, I think of so many molecules that you've led over the years and new bispecifics. You've already intimated that we've got new CAR T cell therapy coming that may be as effective, if not even more effective than what we have now, and importantly, safer. Then there's other small molecules coming like cell mods and so on. But what excites you the most about really new approaches to therapy? Is it the next generation CAR T? Is it the next generation bispecifics? Is it tri-specifics? Is it tetra-specifics? I mean, what do you think?
I think that CAR-T is becoming safer is probably going to be one of the most effective therapies. But as we know, these are things that can only be given in tertiary centers. So the vast majority of the myeloma patients may not have access to some of these cellular therapies. And just like transplant, even in the US, only 30% of eligible patients ever got transplanted. So I
Yeah.
suspect that's going to happen with CAR-T as well. But I don't feel as disappointed because we have bispecific antibodies either used in combination or the trispecific antibodies that are giving responses as deep as what we are seeing with the CAR-T. So it's quite likely that everybody is, irrespective of where they are, will be able to access the most effective therapy that is available. So I think the trispecifics are important both from its depth of response standpoint and also the theoretical possibility now to be determined in clinical trials that the responses will be much more durable because they won't get resistant since we are going after two different targets. And the same approach is happening with CAR Ts too.
Yeah, I mean, it's interesting you say that because, historically we've proved, like, remember the early days? I remember when we used to say, okay, are we going to use bortezomib or lenalidomide frontline? And we realized bortezomib, then lenalidomide, or lenalidomide, then bortezomib was inferior to adding the two of them together to begin with, right? The idea, as you said, of overcoming resistance. So I do wonder, I mean, you've just presented as a late breaking abstract the combination of talquetamab and teclistamab together at the European meeting. Do you think then that if you had a single molecule that brought those two drugs together, these two targets together, let's say BCMA and GPRC5D, let alone other targets like FCRH5, which is coming, you think that'll be more durable than doing it with sequential two drugs?
I think so. I think going after two targets is going to be important in this disease. And as you just said, with everything that we have learned over the past 2 decades, is you cannot just go after one target. I think the myeloma cells are too clever for us to be able to get away with just one or using different ones sequentially. So I think going at the myeloma cell with two or three different approaches simultaneously is probably going to get us to that deep response. That is probably the best way to get the good long-term outcomes in these patients.
And do you think paradoxically, Shaji, that even though in a sense we're combining two drugs and we're hitting two targets, that this actually might also mean less toxicity? I mean, I was quite impressed with the tri-specifics because there seemed to be less toxicity, partly because they were giving the drugs less frequently. But maybe if you have that tri-specific approach and you're more sensitively achieving adherence to the myeloma cell, you're not hitting as many of the other cells in, a friendly fire, as it were.
Absolutely. I think we can operate at the lower end of the therapeutic window for each individual drug by using this multiple drug combination. And as a result, we are seeing less overall toxicity, but still maintaining the efficacy. I think that's what we are seeing with all these. But again, I think it's just not immunotherapy. I mean, there are a lot of biology of the plasma cells that we are understanding better that is pointing us towards other therapies too. So venetoclax or BCL2 inhibitors for patients with 11-14. There are MMSET inhibitors that are being developed for patients with 414 translocations. Obviously, there are drugs, again, that are targeting the different signaling pathways that could play a major role, especially in those patients with high-risk disease or disease that is outside the bone marrow, the extramedullary disease that is such a difficult thing to deal with in the clinic, where even the immunotherapy often tends not to give the results that we would like to see.
Well, you heard it here first from Dr. Shaji Kumar. Shaji, this was a fantastic conversation. Thank you so much for your insights. We've talked today about enhanced diagnostics of being able to detect the disease more accurately, more easily, more conveniently for patients with potentially less bone marrows. We've talked about frontline therapy, moving towards more immunotherapy-based approaches with deeper and more durable responses, and even now in relapse, the next generation CAR T, with really perhaps a theme through all of our chapters today of a much more individualized and personalized approach to multiple myeloma. So I have been so excited to see what's happened in myeloma in the last 20 years. It boggles my mind to think what's going to happen in the next 5 to 10, if not 20 years, where hopefully we can start to use the word cure even more. We saw results this year of a long-term follow-up of CAR T where a third of patients were still disease-free at 5 years. We're not saying they're cured, but it has clearly caused us as a myeloma community to have to come to the definition of cure. So let's wrap things up here. Today, we've had the privilege of talking to Dr. Shaji Kumar about the future of multiple myeloma. Thank you so much for joining me, Shaji. It's always such a pleasure to share the stage with you. And thank you to our audience for tuning in. Please take a moment to download the Medscape app to listen and subscribe to the podcast series that we have here on multiple myeloma. This is Dr. Joseph Mikhael for the Medscape In Discussion Multiple Myeloma podcast. Thanks again.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on multiple myeloma.